Welcome. My name is Jackie Cona. I'm a speech-language pathologist in our Leukodystrophy Center for Excellence. Soon you will meet my colleague, Julianne, who is another speech pathologist in the Leukodystrophy Center. This presentation is really going to focus on the impact of leukodystrophy on feeding and swallowing. Disclosures, we are salaried employees at CHOP. So next slide, we are really going to describe our role in the Leukodystrophy Center for Excellence. So our clinical evaluation is really focused on oral feeding and swallowing skills. We screen for communication and language skills. However, they're not directly assessed within our clinic visit. We ask screening questions and really determine if a need for a more comprehensive evaluation is needed. So some children benefit from alternative means of communication, and that's best served by our colleagues in the outpatient and community-based environments. On the next slide, we are going to discuss kind of how leukodystrophy may impact swallowing liquids. Julianne and I will kind of go through each consistency and how it may affect, and things that you may see at home, and then strategies that you or a speech pathologist can help with some of these things. So what you may see with liquids. So you might see reduced efficiency. So a small sips, or if they're bottle feeding, multiple sips per swallow, difficulty pulling the liquid out of the bottle or up a straw, difficulty closing their lips down on a spout or a straw. You might see some biting down to get some jaw stability, or just difficulty with their lip movement. Sometimes you'll also see some reduced coordination of that swallowing and breathing pattern. So you'll see loud gulping, despite having like a typical sip size. Some high-pitched or squeaky swallows, or high-pitched breathing, almost like a wheezing sound when a child is bottle feeding. Sometimes you see liquid coming out the front of their mouth, and this might be due to the sip being too large, or their tongue movement, instead of pushing the liquid to the back of their mouth, pushes the liquid actually forward and spills out the front. Bottle feeding may take a long time because they need those extra sips per swallow due to some reduced strength. Sometimes with bottle feeding, we also see stress cues such as gagging or arching or falling asleep because it takes so much effort. Because of this, sometimes it's difficult for kids to take their full volume of liquids just by mouth. So that is a discussion that we'll have with the family or the medical team to decide what is the best way to provide hydration. And then just difficulty transitioning off the bottle. So some strategies that we can use to help with intake of liquids. So making sure that a child is using the best modality for efficiency and ease and safety. Sometimes we can change the way that they take liquids. So we've listed a bunch, but some of the less common ones is the honey bear cup. You can see a picture in the top right-hand corner. That's to assist with straw drinking. And then below you see the nosy or cutout cup that we use for open cup drinking. So on the next slide, we are going to discuss purees. So things like applesauce, pudding, things that you don't need to chew. So sometimes we see some oral motor difficulties. So difficulty with mouth opening, or when their mouth opens, their arms or legs get a little bit more tense, some of that overflow movement. You might see decreased lip closure around the spoon and difficulty getting the food off the spoon. So sometimes parents say that they'll scrape the food off using the upper teeth of the child to help with that movement. You might also see mouth movements to try and move the food to the back of the mouth. It might be a little bit different. Sometimes the tongue comes forward in an attempt to move the bite backwards, or you might see a continual suckle pattern where they're just moving a little bit at a time to the back of their mouth. This may take more time for them to complete and fully transfer a bite of applesauce, let's say. So you might also see some pocketing or leftover food if they're not able to fully clear their mouth. So strategies that we use. So you can use a flatter spoon with less of a bowl, and this helps the child remove the bite from the spoon, reducing the bite size so it's a little bit easier to control or manipulate, and increases the efficiency with taking each bite. You can also put some downward pressure using the underside of the spoon on the tongue surface and swiping up. This helps with clearance from the spoon, as well as hopefully getting a more typical transfer pattern from the bite from the front of the mouth to the back of the mouth. And then oftentimes it's just really important to slow down and give them enough time to clear their mouth before offering the next bite. So Julianne is now going to discuss chewable solids. So thank you so much. And I'm going to give it to Julianne.
So next we're going to talk about chewable solids. So sometimes what you'll see is an immature chewing pattern. So a typical or mature chewing pattern is more of this rotary circular movement, and an immature pattern looks more vertical, this up and down movement. You also may see tongue mashing of the food against the roof of the mouth or palate. The solid may not be fully broken down, and they may swallow some of it or all of it whole. They may need more time for each bite, and this could result in really long meal times, such as 45 minutes to an hour, to consume just a small meal. You might see choking or gagging, which would be a safety concern. The swallow may look effortful or like they're trying really hard to do it. You might see food or residue left in their mouth or on their tongue. So what can you do to help? Choose foods that are appropriate for their chewing skills and not necessarily just their age. You can switch to foods that are easily fork mashable or purees that don't really rely on chewing. You can moisten the solids. This helps break down the solid and helps it stick together to be swallowed. You can go to smaller bites. This decreases the amount of chewing they actually have to do at a time for that bite. Avoid high-risk choking foods if the child does not have the oral skills to safely eat them, such as gummy candies or hot dogs. You can place the bite on the side of their mouth so that it's in place for chewing right there on the side of their teeth. You can alternate giving liquids and solids. So by giving them a sip of liquid after a bite, this can help clear any residue that might be left in their mouth. You can alter the structure of the meal. So one thing you can try is doing solids first, the chewables first, and then progress to doing something easier like purees. You could offer 1 to 2 chewable foods per meal and the remainder be liquid or purees. These strategies decrease the amount of chewing that they need and may actually help decrease fatigue when they're eating and maybe make meals a little bit faster. You can also add sauces and condiments because this increased sensory input can actually help with chewing because they have an increase in flavor. On the next slide, we're going to be talking about what we think is the most important, which is swallowing function and safety. So some things that you may see that would be concerning for safety would be audible gulping or squeaky swallows. This is typical for everyone if they're drinking large amounts of liquid at a time, but it's concerning if it's frequent and it's happening with just normal size sips. They might have high-pitched swallows. They may be doing a lot of swallows just for one bite or sip. There might be signs of aspiration. So this would be coughing, throat clearing, even if it's minor after the swallow, a wet vocal quality, congestion or wet breath sounds in their breathing after they swallow, recurrent respiratory illnesses, chronic cough or chronic congestion, and recurrent fevers. So some strategies that you can do would be to decrease the bite or size sip. You can do slower rate of feeding or eating, so just making the meal slower and implementing a lot of breaks. You can change the equipment of how they're eating, just as Jackie previously discussed. You can thicken liquids. If you're thickening liquids, we're recommending doing this under the guidance of a speech pathologist. The rationale for this is that thin liquids or regular liquids move really quickly through your mouth and through the swallow, through your throat when you're swallowing. So if you thicken the liquids, it gives the muscles and the structures increased time to manage that liquid and can help with better coordination during the swallow. It's always important to discuss with your medical providers and the family the goals and status of feeding, such as feeding for pleasure versus feeding as the primary way of getting nutrition. On the next slide, we're going to talk about swallow studies, which you may have heard of before. So what is a swallow study? A swallow study is a moving image of the swallow. So we are going to be watching food or liquid move all the way from the mouth all the way down to the upper esophagus. It looks at the function of the swallow as well as the presence of aspiration or liquid or food going towards the airway. During a study, the child will drink barium and will also add barium to foods if the child eats food, so we can see exactly what's happening with that food on the image. A swallow study would be recommended if there's any concerns for aspiration or swallowing safety, a decline in swallowing function, overt clinical signs of aspiration like we just discussed, or potential symptoms of aspiration, such as respiratory illnesses, coughing, unexplained fevers. So what we would recommend if there is concern, discussing with your medical provider and or a speech pathologist if a swallow study is indicated. Okay, thank you for listening to our presentation on feeding and swallowing.